Our body tells us when something isn't quite right, like when we place our hand in hot water or sense danger while watching a horror movie. Listening to those signals can make a huge difference, especially when it comes to your vascular system. Peripheral artery disease, PAD for short, is a lot more common than one would think. There are clues that PAD gives our body to let us know if we are suffering with a condition, like painful leg cramping after common activities, cold legs or feet, sores that won't quite heal, skin color changes, or a decrease in hair growth on your legs. If any of these symptoms are giving your body signals, it could be PAD. Left untreated, the disease can lead to amputation, stroke, and even heart attack. The next step is to ask for help. At St. Luke's, our trusted team of cardiologists and vascular surgeons have extensive experience treating the condition. So, if your body is giving you signals, listen and schedule an appointment today.
Hello and welcome to the St. Luke's PAD Community Awareness event. Thank you so much for joining us. I'm Matt Bunte. I'm an interventional cardiologist with the St. Luke's Health System. I'm pleased to be here today to speak to you about risks associated with peripheral artery disease. So our first topic of today is going to be talking about the specific cardiovascular risks associated with peripheral artery disease and really what you need to know if you have the condition to reduce your risk for complications. We'll cover today the basics of peripheral artery disease. We'll talk about those risks associated with PAD and treatments that lower your cardiovascular risk. So today we'll talk about peripheral artery disease, also known as PAD, which is a serious medical condition. PAD is associated with impaired blood flow to the arms and legs and may be the first sign of more serious problems of the cardiovascular system. Did you know that PAD is most commonly asymptomatic, and many patients who have the condition may have atypical symptoms or no symptoms at all? With PAD, diabetes is very strongly associated, and together those two conditions increase the risk of amputations of the leg. PAD is also associated with a high risk of heart attack and stroke, which we'll cover today. But the best news is that PAD is certainly treatable, and those risks can be certainly reduced substantially. So first is about awareness of PAD and being aware of the causes as well as the symptoms of PAD, and really knowing the risks of PAD is important to understanding the treatments to lower your risk and the treatment options to improve your quality of life as well. The risk factors for PAD include smoking, diabetes, advancing age, high blood pressure, excess weight, a family history of peripheral artery disease, and high cholesterol. But perhaps the most important of these risk factors, and ones we'll focus on today, are diabetes and smoking. Those two factors are quite strongly linked to the development and progression of PAD. PAD occurs because there is atherosclerosis or fatty cholesterol deposits that develop into the arteries that reduce the blood flow, essentially plug the pipes, and cause symptoms and other complications associated with PAD. But keep in mind that PAD is associated with plaque buildup in the legs, and while that certainly is associated with the syndrome, this process of atherosclerosis is really systemic, meaning that it occurs everywhere in your body. And so we'll talk about how that chronic artery inflammation and clotting in the arteries leads to other complications. And while peripheral artery disease is most commonly asymptomatic, some patients, about 10 to 15% of patients, develop claudication. Claudication is pain in the legs when you walk, and classically claudication occurs with cramping of the calves or buttocks or hips, but can occur more subtly with weakness or fatigue in the legs. If you have these symptoms, your doctor can order a simple test called an ankle brachial index to confirm that perhaps PAD may be part of the problem. More advanced patients with PAD develop chronic limb-threatening ischemia. Basically, the artery disease becomes so severe that the blood flow to the feet particularly becomes reduced and ulcers develop, and those ulcers can lead to non-healing wounds and potentially amputation. PAD essentially, in all of these forms, restricts blood supply, which causes muscle pain. And this is a phenomenon of supply and demand. Blood supply is normal with normal arteries, but as those arteries become more and more plugged with atherosclerosis, when we exercise, our muscles aren't able to keep up with the oxygen demand, and consequently, PAD causes our legs to hurt. So the symptoms of PAD to be aware of are exertional leg pain, as we've talked about, cramping, heaviness, or fatigue. In more advanced forms, we can see signs of lower extremity hair loss or coolness, numbness, or skin or color changes in the feet. And at the later stages, non-healing wounds or gangrene of the feet or toes can be a real problem. But the most important factor, and what I alluded to earlier, is PAD is really a form of atherosclerosis that affects the legs, but this is really a systemic disease process and needs to be treated as such. In fact, peripheral artery disease patients have 5 times the risk of heart attack, 3 times the risk of stroke, and in those with diabetes, 2 to 4 times the risk of major amputation of the legs than people who don't have PAD. So it's very important, if you have PAD, to understand these risks and keep in mind what we'll talk about here in the next slides about the ways you can reduce that risk. And just like coronary artery disease involves blockages of the heart arteries, so too does PAD. It's associated with the same form of plaque development or atherosclerosis. And the good news is we have ways to reduce that plaque progression. It's important to keep in mind that patients with peripheral artery disease, represented in the orange bars here, have a relatively high 5-year all-cause mortality. And when you put it into perspective with patients with other serious conditions such as prostate or breast cancer or acute myocardial infarction, also known as a heart attack, colon cancer, stroke, or lung cancer, patients with PAD are quite high risk, and it's due to these issues of systemic atherosclerosis. So I'd like to just talk to you about how you can lower your risk by following a simple mnemonic of the ABCs. So we'll talk about these in detail, but here are the ABCs, and we'll go through these each. So the A stands for aspirin and anticoagulants. We'll talk about how those medications help to lower your risk. Blood pressure control is essential, as is cholesterol. But diabetes, as I mentioned earlier, is very important with implications for the population with PAD. Getting plenty of exercise is critical, and we have some goals for patients with PAD to follow. And then being fit and fresh, including don't smoke, or if you do smoke, quit smoking, and then eating a healthy diet really makes a big difference in lowering your risk. Let's start with aspirin and anticoagulants. Patients with peripheral artery disease, as I mentioned, have this problem of atherosclerosis, or buildup in the arteries, which doesn't just affect the legs. In fact, it affects the heart as well, which is why patients with PAD are at such high risk. So we use aspirin and anticoagulants because those conditions of heart attack and stroke are associated with sudden clotting in diseased arteries to lower that risk. Blood thinners such as aspirin help to reduce the risk of clotting, but for patients with symptoms of PAD, the benefits of aspirin tend to outweigh any risks of bleeding, although it's important to talk to your doctor if you have a history of bleeding to decide if aspirin is right for you. Now, patients who have had prior balloons or stents or bypass may also benefit from another medication called rivaroxaban or Xarelto. Now, this is important to spend a moment on because this dose of Xarelto is unique. There are many patients who take Xarelto for other conditions that we treat in our cardiology practice, but this dose is rather unique for the patients with coronary heart disease or peripheral artery disease to lower your risk. That being said, this combination of therapy does seem to lower the risk of clotting complications quite substantially. So in patients who have had prior procedures to treat their PAD, this may be a medication, the Xarelto, that your doctor adds to aspirin to further lower your clotting risk. Let's talk about blood pressure. I think over the years, blood pressure has become a real focus in preventing many cardiovascular disease complications. And so high blood pressure is a very important focus for patients with PAD. High blood pressure, or hypertension as we call it, is when the force of blood is too high in your arteries. Nearly half of Americans have high blood pressure, so this is a very common problem. And controlling blood pressure in patients with PAD lowers the risk of complications. And we talk to our patients with PAD about monitoring blood pressure at home and really being familiar with how your blood pressure is changing day to day, and keeping tabs on that really helps me as a physician to partner with my patients to achieve a target blood pressure of less than 130/80. So keep in mind that 130 is too high for blood pressure. If you're noticing that your blood pressure is consistently over that mark, talk to your doctor about ways in which you can lower your blood pressure safely. Certain medications are preferred for patients with peripheral artery disease to lower their blood pressure, and those include examples like lisinopril or losartan, although there are many other medications in those classes to help lower your cardiovascular risk. Always take your blood pressure medications and all your medications as prescribed, as the benefits of blood pressure control in most cases outweigh the risks of low blood pressure, although certainly if you've had low blood pressure issues in the past, talk to your doctor about what regimen might be best for you. Now, cholesterol isn't inherently bad, but this is a very important opportunity for many patients with PAD to lower risk. We know that over half of Americans with PAD aren't treated with medications to lower their cholesterol and thereby lower their risk. So really understanding your cholesterol levels and how important cholesterol treatment is to lowering your risk is really key. You should be aware of your overall cholesterol numbers, but particularly familiar with your low-density lipoprotein. We abbreviate this LDL. And LDL is really the inflammatory component of your cholesterol panel that leads to that fatty plaque buildup, or atherosclerosis as we call it. And we know that patients with PAD that control their LDL level to less than 70 tend to have lower risk of heart attack, stroke, and other complications. So just like your blood pressure, I ask patients to become familiar with their blood pressures. Also know what your cholesterol numbers are, and specifically your LDL. Now, statins are the most common form of cholesterol-lowering drugs, and while no medication is without potential side effects, statins tend to be very effective in lowering cholesterol and have benefits that far outweigh any risks associated with adverse events. Statins disrupt production of cholesterol, and along with a healthy diet and exercise, statins lower LDL cholesterol to prevent plaque buildup within the arteries. Statins lower the risk of complications associated with PAD by 40% or more in some populations, and are really a key piece of the way we lower cardiovascular risk, including heart attack and stroke among patients with peripheral artery disease. High-intensity statins are best at lowering risk. So it's important to note that while being on a statin is important, being on a high-intensity statin is really our goal. And I should note that high-intensity statin therapy is recommended regardless of your LDL level. So even if your LDL level is less than 70, we still try to use high-intensity statins because they are so effective in lowering cardiovascular risk. Now, what do I mean by high-intensity statin? Well, there are two particular statin medications, both of which are generic, that we use. Atorvastatin, also known as Lipitor, in a dose of 40 to 80 milligrams per day, and rosuvastatin, also known as Crestor, in a dose of 20 to 40 milligrams per day. These two medications at those doses seem to be particularly effective in lowering the risk of complications associated with peripheral artery disease. Now, some patients may not tolerate statins, and that's okay. There are ways to potentially help reduce the risk of complications, and your doctor is familiar with those strategies. Really, I think the most important thing to share with you today is to talk to your doctor about your concerns, as the benefits of statin therapy generally outweigh significant risks associated with the medications. Now, for patients who cannot take statin therapy, there are new medications to market that are particularly effective in lowering the LDL. And those medications are monoclonal antibodies. So what that means is these are antibodies to a receptor in the liver that must be injected. If you eat the medication, your body, your digestive system would destroy the medication. So we have to inject this under the skin. And by doing so, these medications help to lower the amount of cholesterol in your bloodstream and effectively lower LDL. There are 2 medications currently on the market. Both of these are proprietary and expensive specialty medications. One is called Repatha or evolocumab. The other is Praluent or alirocumab. Both of these medications come in a metered dose pen, as I've shown here with examples, and simply requires the patient to self-administer the injection by pressing the pen up to the skin, usually on the leg, and following the instructions to administer the drug. Let's shift focus now to diabetes. Diabetes mellitus, or diabetes, is a condition that causes blood sugars to rise. And like hypertension, diabetes is increasingly common in our United States. And locally here in Missouri, 1 in 5 patients over age 65 has diabetes. So if you have diabetes, controlling your blood sugars to prevent serious complications, including peripheral artery disease, is really key. If you have diabetes and you have PAD, there are significant risks you must be aware of, including the risks of diabetic foot ulcers and the risks of amputation associated with those ulcers. Knowing your fasting blood sugar and A1C results, just like knowing your blood pressure and your LDL cholesterol, are really key in the partnership in working with your physician to lower your cardiovascular risk. And working with your health team to understand how diabetes medications lower your risk is also really important. There are many new medications coming to market that seem to be particularly effective in this, and so it's important that you're familiar with these medications and how they might benefit you. Certain medications are particularly important, as mentioned, and I wanted to share just 2 new medication classes that you should be aware of. One is the GLP-1 receptors, which GLP-1 is a protein in your digestive system that helps to improve the use of insulin to help effectively lower blood sugars, as well as many other benefits to patients with diabetes. But this medication also seems to help dramatically lower cardiovascular risk, along with other benefits like weight loss. In fact, GLP-1 receptor agonists have a 20 to about 40% risk reduction in cardiovascular risk in large clinical studies that have been recently completed. Another class of medication you should be aware of is SGLT2 inhibitors. These are medications like Jardiance or Farxiga, and they help to lower blood sugar by helping the kidneys to excrete sugar in the urine. These medications help reduce weight and also lower cardiovascular risk, but have other benefits, including lowering the risk for patients with heart failure and reducing the risk of kidney complications. SGLT2 inhibitors in studies recently have shown a 43% reduction in the risk of cardiovascular death. And what's unique about GLP-1 receptor agonists and SGLT2 inhibitors is their dramatic benefits in lowering cardiovascular risk. These are 2 medications. If you have diabetes, you certainly should talk to your doctor if they're appropriate for you. Let's shift focus now to exercise. So many times we have a focus on medications and how we can take a pill to lower our risk, but much of the rest of our talk today is about what you can do at home to lower your risk. And exercise is really a key component of that. Starting an exercise program will not only lower your risk, but it will help to improve your symptoms of PAD as well. And I generally like to have patients ask their health provider where to start, but I love walking. Walking is a great place to start, and you can target 30 minutes a day, 5 days a week. By the way, that 150 minutes per week has been shown to reduce cardiovascular risk broadly among many cardiovascular conditions. If you're not able to perform 30 minutes of walking in one episode, it's no problem. Do what's right for you. If it means just starting at 5 to 10 minutes per episode and doing that multiple times a day, that still works and counts. I also encourage my patients to exercise with activities that they enjoy. For some, it's walking. Others, it's swimming or bicycling. But do activities that make it want you to come back and doing things that you enjoy. And I think as you work towards these exercise targets, you'll find that your overall health and well-being is also going to improve. For patients with PAD, we have the option of supervised exercise training. This is exercise training in a cardiac rehab gym where Medicare covers the expense of this therapy. This is 3 days a week over 12 weeks, so 36 sessions of supervised exercise training. And this is probably the single most effective non-invasive treatment to improve quality of life and improve your walking performance for patients with PAD. This supervised exercise training has been shown to improve patients' ability to walk farther and walk with less symptoms than other treatments. It improves overall heart and vascular health, and in many cases is the only treatment needed for PAD, which is great news. Now, I mentioned smoking in an earlier slide today, and I can't underestimate how important it is that if you smoke, quitting smoking is probably single-handedly the most beneficial thing you can do for your cardiovascular health. Smoking also, continuing smoking also increases the risk of many complications, including the complications of failure of therapies, including invasive therapies, which Dr. Vamanan will talk about, as well as increasing the risk of amputations. So if you smoke, don't smoke, and ask your provider about ways to help quit smoking. Smoking increases your general cardiovascular risk, and so in many ways, your breathing, your risk of heart attack and stroke will also benefit from quitting smoking. Now, diet is another thing that is not to be underestimated and is something that is hard for us, frankly, to change, but in small ways we can make dramatic improvements over time, just like with exercise. Eating a low salt or a low sodium diet, and I ask patients to shoot for less than 2 grams per day, by primarily limiting processed foods, such as canned or dried or fast foods, and really cooking fresh. And using herbs to season food is really helpful to lower the sodium overall in the diet. Consuming fresh fruits and vegetables for a high fiber diet is a great way to lower cardiovascular risk, helps us to maintain a healthy weight, and really making fruits and vegetables the centerpiece of what you eat and the primary source of your nutrition is a great way to make changes of a heart-healthy diet. To wrap up, shared decision-making around peripheral artery disease is increasingly important. And you should know that your physician should be a partner with you in making sure your symptoms as well as your cardiovascular risk reduction goals are met. And returning for those follow-up visits to ensure your fitness level and quality of life goals are being met is quite important. Enhancing engagement and communication between the doctor and patient is also an important opportunity with chronic care that PAD requires. And patients with PAD with aggressive reduction in their risk factors and control of their blood pressure, cholesterol, blood pressure being a particularly important one, diabetes control, those really do matter in lowering your long-term cardiovascular risk. For more information about anything I spoke about today, I'd refer you to the American Heart Association's www.heart.org website. This is a tremendous resource with really patient-focused educational materials that are well thought out and explained. And anything I covered today, if you have questions or if anything you'd like to elaborate on more, this is a great tool and resource. And in fact, the American Heart Association recently released their National Action Plan to focus on making sure that we're providing great PAD care to all communities. So to summarize today, PAD is a serious form of cardiovascular disease. Follow the ABCs to lower your cardiovascular risk. And I'd encourage you to engage your healthcare team to find ways to lower your cardiovascular risk with all the points we covered today. Well, it really was my pleasure to join you this morning to talk about peripheral artery disease and ways you can lower your cardiovascular risk. I'd encourage you to engage your healthcare team in making sure that your quality of life and cardiovascular risk reduction goals are being met. I'd now like to turn it over to my colleague, Dr. Karthik Vamanan of vascular surgery, who will talk to you today more about invasive treatment options for patients with peripheral artery disease. Thank you.
Good morning, everyone. Thank you for joining us this Saturday morning for PAD Awareness Month. Thank you, Dr. Bunte, for going over medical treatment of PAD and causes of PAD. I'm going to go over some surgical options for the treatment of PAD and get started here. The most important takeaway, if there is going to be one from today's talk and from today's session, is that PAD does not have to be treated. So just because you have a diagnosis of PAD doesn't mean that you immediately need to be treated for it. Like Dr. Bunte said earlier, we only treat PAD if it is causing problems. When we identify patients with PAD, we have the opportunity to modify their risk factors and overall improve their cardiovascular health and mortality. PAD exists as a spectrum. So peripheral arterial disease is where you have blocked arteries and there's a problem with your circulation. But people with PAD can exist on a spectrum ranging from asymptomatic patients or patients without any symptoms to patients that have tissue loss or what we call limb loss, and they have wounds that cannot heal or cannot be treated, and gangrene. So it exists on a spectrum of lack of oxygen. So if the decrease in oxygen supply is just minor, they're asymptomatic, but as that decrease in oxygen supply gets worse, they start having pain when they walk, and as that continues to get worse, they don't have enough oxygen to even sustain their tissues when they're not doing anything. They start having pain when they're not doing anything, and eventually will develop wounds because of lack of oxygen and can progress to gangrene and eventually lose their legs. When we identify patients with PAD, the initial testing always consists of non-invasive testing, and this is the key to the treatment of PAD. What we do with non-invasive testing is quantify blood flow. Not all tests for PAD can actually do this. We only obtain anatomic studies like CT scans, MRIs, or angiograms if we need to obtain them and if we've already decided to treat the PAD. The most basic test to diagnose PAD is called an ankle brachial index. It is a very simple physiologic test. We obtain a blood pressure in the arm and we obtain a blood pressure at the level of the ankle, and we compare the two. If they are equal or near equal, that usually means that the circulation is normal in the foot like it usually is in the upper extremity. If it is decreased in the foot, we can tell here easily by a decrease in what is called the ankle brachial index, or the comparison of the two blood pressures. Here's an extension of the ankle brachial index. This test is called segmental pressures. We put blood pressure cuffs on various levels as indicated in the schematic on patients' legs, and we look at the pressures and the waveforms of the blood going through there, and we can usually tell if patients have blocked arteries at one level or the other and compare the two sides as well. This is another test that is a physiologic test. We put patients on a treadmill. It's kind of like a stress test for the legs, and we look at the blood pressures as they walk, and you can tell here that there is a significant decrease in blood pressure when the patient walks, and also at baseline, which tells us that they likely have PAD that is significant enough to cause problems. Once we're done with the physiologic testing, we can move on to more definitive testing that then identifies the areas that are blocked, and we can start with basic tests like an ultrasound, and then we progress up the chain of testing to CT, MRI, and eventually an invasive test called an angiogram, where we put a catheter in your arteries and shoot some contrast down your arteries and look at it under X-ray to tell where the blocks are. Like I said earlier, not all PAD needs to be treated, but when we have decided to treat PAD, we have multiple options. I'm going to start off with the least invasive options, and we can treat some PAD with balloon angioplasty alone, and we can treat some PAD with balloon angioplasty alone. Balloons are catheters that are inserted over a wire, and they're placed across an area where the artery is blocked, and then we inflate the balloon to expand the block and to get the artery open. Here's an example of a patient. On the video on the left of your screen, you can see the patient's leg and foot, and you can see that the arteries are blocked as they go down to the foot. In the picture in the middle, you can see that we've crossed that block with a wire. That is the bright object that is going through the dark line. That is the artery. And on the right, on this video, you can see that the artery has now been opened with a balloon, and the patient has much improved blood supply to their foot. Multiple balloons have been developed that help improve patency of treatment, and by patency I mean the chance that they are going to stay open longer. We have drug-coated balloons that use a chemotherapeutic agent that prevent scarring and help prevent the artery from closing down after we've angioplastied them. We also use cutting balloons that have knives on them, and we have newer balloons called shockwave balloons that help us break up calcium in these blocks and help expand the arteries in a relatively stable fashion. Sometimes we have to use stents. Stents help keep arteries open, usually after we've treated them with a balloon. We also use stents to treat aneurysms and injuries to arteries. Here are two examples of stents. The stent in the left upper corner is a covered stent, as in it has a fabric covering it. This is the kind of stent that would be used to treat an aneurysm so blood doesn't get out of the stent. The stent in the lower right corner is a bare metal stent, as in it is a stent that is just made of metal without a fabric covering, and we use this stent most commonly in the peripheral circulation to get arteries open. Here is a video on the left of an artery that is blocked. You can see on the right-hand side of that video, the artery is blocked and does not demonstrate continuous contrast or flow through it. On the video on the right, you can see we've slowly started to get that artery open now. There's a wire going through that artery, and we've made some progress in getting it open. And as we continue, you can see in this video, we've opened it up a little bit more with balloons. And the final video shows the artery after it has had a stent placed in it. And you can see, like on the right, the artery is now wide open, and the patient has much improved blood flow to that leg. Here is an example of opening arteries using what we showed earlier called the covered stents. On the video on the left, you can see the patient's aorta, which is the biggest artery, and as it comes down, you can see on the right there's no flow at all. And there is some clot in that artery as well. And on the video on the right, you can see that that artery is now wide open. We've put in what is a covered stent extending all the way into the aorta, and there's good blood flow down to both the legs at this point. There are limitations to stent usage, as you could imagine. Stents are made of metal and generally don't work well when placed across a joint. So stents can only be used in arteries that do not cross a joint where they move and fold and bend. Sometimes in these situations we have to do what is called a bypass. So essentially we create a bypass around the blocked artery, and we can do this using either your own vein or an artificial material. It works best when we use your own vein because it lasts the longest time. You can see here on the video on the left that this patient has blocked arteries in the abdomen. That's the aorta and the iliac arteries. And we've got that iliac artery now open with a stent. And as we go down the leg on these pictures, you can see that the patient has very significantly blocked arteries coming down the leg. And the rightmost picture is a picture of the patient's leg and foot. And what this patient needed was a bypass, and you can see here this is how patients with bypasses end up. We use the little incisions along the thigh to remove the vein, and we plug the vein into the artery which is open in the groin and plug it into the artery below the knee where it is open again, restoring blood flow to the patient's foot. When bypasses are not possible, and we also cannot treat patients with balloon angioplasty and stenting, we have new techniques. One of these is deep vein arterialization. This is where we convert the veins in the body into an artery. And I'm going to show you an example here on the video on the left. As we're coming down the patient's leg, you can see that they have some blocked arteries, and on this last picture on the right, you will see that that's the patient's foot, and we don't see much in the way of arteries on that foot as everything's blocked at the level of the ankle. What we did for this patient was take his vein and hook it up to the artery above the knee, and you can see now that there's blood flow coming down that vein into the foot because we've essentially converted that vein into an artery. And you can see here on this video that now the patient's foot is getting a lot better blood flow. And this is now through the venous system. So we're actually redirecting the blood flow in the veins to make the blood actually go backwards down the vein into the foot when it usually should come back up towards the heart. The St. Luke's Mid-America Heart Institute has a vascular program that I'm very proud of. It is the only true multidisciplinary vascular program in the Midwest. We have multiple specialties working in the same area, treating PAD. We have a combined office. We offer the most advanced modalities for the treatment of PAD, and we almost always have an option for PAD that's hard to treat. So if you get somebody telling you that you don't have any options, please do give us a call and see if we can offer you something. And hopefully you never need to be treated for PAD. I'm going to go over our most important takeaway again at the end of this talk. PAD does not have to be treated. So just because you have a diagnosis of PAD, it does not have to be treated. We only treat PAD if it is causing problems. The diagnosis of PAD helps us identify patients with PAD and modify their risk factors to improve their overall cardiovascular health and mortality.
Thanks, Karthik. My name is Anthony Grieff. I am one of the vascular surgeons at St. Luke's, and today I'm going to be discussing peripheral arterial disease and how it relates to limb salvage. So when a patient first comes into my office, oftentimes they're complaining of leg pain. And the first thing in my mind is to try and understand what that leg pain is from. I have some patients that come in who have musculoskeletal pain. Often that is pain in the muscles with palpation or pain in the joints with range of motion. I can also have patients come in with nerve pain. We call this neurogenic claudication, and it's the result of either pinched nerves in the spine or pinched nerves in the legs, things like sciatica. And typically patients are going to report pain in their legs that is dependent on different kinds of positions and often going to have a shooting or electric quality in the leg. We then move on to vascular leg pains, and the first one I think about always is artery pain or arterial pain. And typically patients are going to report that they have pain with walking, either in their calves, buttocks, or thighs at fixed distances. And the important thing to understand with this is that it's a blood supply issue, so it's going to occur every time a patient walks at a fixed distance. And it's typically not going to be related to positional changes. Finally, I think about venous leg pain, and that's oftentimes people or patients that have prominent veins or varicose veins in their legs, and often are going to talk about aching or soreness at the end of the day or with prolonged standing. So specifically, I want to talk a little bit more about peripheral arterial disease today. And the key thing to understand is first the risk factors. And for peripheral arterial disease, smoking is the #1 risk factor. That's typically the first thing we talk about with any patient when we talk about peripheral arterial disease, whether it's a patient who has asymptomatic or a patient who has pain with walking or even starting to have tissue loss. We then start to control things like blood pressure, diabetes, cholesterol, and heart disease. But ultimately, one of the biggest risk factors for PAD is age and can be a natural process of aging. Patients often ask me about why they have pain in certain areas, and it's important to understand that when you have a blockage in an artery, you have pain the one level below that artery. So for patients who have blockages in their pelvis, they tend to complain of pain in their buttocks or thighs, and with patients with blockages in their thighs, they tend to complain of pain in their calves and so forth. So let's talk a little bit more in depth about patients with PAD. And this is one of the things that I talk to a lot of patients about when they come to see me in the office as well. And the first one is patients who have asymptomatic disease, meaning these are the people that have no symptoms, no pain that hurts their legs on a daily basis, who have some sort of testing, and they're found to have blockages or disease in their arteries. The important thing with these patients to understand is that no procedure should be done. These people should be treated medically, and I feel very strongly that only patients with symptoms should ever be offered interventions. We then talk about patients with claudication or pain with walking. Typically, first-line treatment for these people is going to be medical treatment, but occasionally we talk a little bit about interventions when there are lifestyle-limiting symptoms. And then finally, there are patients with critical limb ischemia or tissue loss where treatment is often and should be performed in order to salvage limbs. So a little bit more about claudication. You know, one of the most important things I try and explain to patients is that one of the most important reasons not to have interventions for non-severe pain is that the natural history of claudication or vascular walking pain without treatment is that 70 to 80% of people will stay the same or get better over 5 years, and really only 1 to 2% of people will ever progress to losing toes or having any kind of necessary procedure for vascular disease in the absence of treatment. The goal of interventions is to improve symptoms, but typically a lot of these people can be managed with medical management, which includes smoking cessation. It includes placing people on certain medications, and it also includes placing patients on exercise programs, which have been shown to increase pain-free walking distance without the need for surgery. When we talk about tissue loss as well as pain at rest, we talk about kind of two flavors of patients again. We talk about patients who have primarily vascular disease. These are people that have such severe disease that blood isn't even getting to the very tips of the toes, and oftentimes patients are going to start to come in with black toes or wounds on the little tips of their toes that aren't healing. We also talk about this other big group of diabetic patients, and this is in some regards a more common patient group where it's patients that have some blockages, but not always enough to lose toes on their own. When a diabetic patient gets a really bad wound on their toe or their foot, as seen in the picture, oftentimes that wound will become stagnant, not only because of decreased healing ability in the diabetic patient themselves, but also because when we talk about maintaining tissue, it requires a whole lot less blood supply to keep what's there than it does to start fixing or healing a wound once it's happened. And whenever we see these patients, I firmly believe that interventions are necessary as we're able to have a lot of success with reducing tissue loss and saving legs. Limb salvage in particular. So these are, again, patients that come in with the black toes or patients that come in with non-healing wounds. And again, treatment is essential in these patients to reduce amputations. Here at St. Luke's and within my own personal practice, we 100% aim to minimize tissue loss whenever possible. Meaning, if someone comes in with a wound on their toe that may have destroyed the toe, we do our best to make sure that we're just amputating a toe and not a leg. My personal philosophy is I always discuss amputation, whether it's a toe or a leg, with patients when it becomes unavoidable. However, I never tell a patient that they need an amputation unless they satisfy one of two things. And that is if they have a life-threatening infection or they have intractable pain that I cannot fix and they are asking for an amputation. Outside of those two things, I never tell a patient they need to have an amputation. And ultimately what I try and do is formulate a patient-centered, collaborative approach. You know, we have a discussion about what healing and what procedures are going to be required to salvage a limb, and if a patient wants to pursue that route, I 100% support them in any way we can. One of the ways we work this up is first with non-invasive testing. We do things with ultrasounds or blood pressure cuffs or sonograms. This is a non-invasive way that can be performed in the hospital or the office, and there's no radiation and minimal discomfort. Occasionally we do require advanced imaging with CT scans or MRIs, and that typically is for patients who are having procedures and used for operative planning. As far as my approach to treating patients with either severe lifestyle-limiting claudication or limb salvage or tissue loss, my first step is always an angiogram, or what's called a catheterization. This allows me to diagnose any blockages and also treat them minimally invasively if they're appropriate to treat that way. Some of the ways I do this is I do it with balloons, I do it with stents, and I do it with atherectomy, or what's called oftentimes roto-rooter. And we do these multiple tools to help restore blood supply to the limb that requires it. Now, it's important to understand that not all blockages are appropriate to be treated with minimally invasive techniques alone, as sometimes treating things in the wrong patient or the wrong location can lead to worse long-term outcomes and at times amputation. The benefit of being a surgeon is that while I perform all minimally invasive procedures, we also perform all traditional surgery. And while, again, it is not first line, there are some patients that will really benefit from bypass surgery or other open procedures to clean up the arteries. And this is typically done to patients who either have issues or reasons to not have minimally invasive again or require larger procedures. I want to thank you very much for hearing my talk, and we're looking forward to seeing you next year.
My grandpa and I have always had kind of a really close bond since a young age. One of my best memories with him is whenever we played piano together. When I was a kid, I took lessons because of my grandpa, because I'd see him playing and I thought it was so much fun and it just sounded really pretty, and so he kind of guided me to that.
I got involved in a gospel quartet. We did auditoriums and things with big name gospel groups and those kinds of things. My actual first church I went on staff to minister was at Coffeyville, Kansas, and they ordained me in 1977. I love helping people. I love working with people. I'm a talker, and I enjoy sharing, and so that's very important to me, and that's a goal in life, is to be able to do it again. I first injured my foot in November of 2019. It was night and it was dark and I had forgot to plug in my phone, so I went to plug in my phone and I accidentally kicked the stereo cabinet. A few weeks later, then it wasn't healing and it was swelling up, so I had some infection under 2 of my toenails and they wouldn't heal. And first thing I know, within a month or so, I've got gangrene started in my left foot.
These foot ulcers can be very challenging to treat if only focused singularly on the ulcer itself, because there's often a component of blood flow and a lack thereof really to the wound that leads to the progression of the wound and often the lack of healing.
The doctor wanted to schedule me to take my leg off, and I said, no. I want to investigate every possibility of saving my leg that I can find. We were working on trying to heal that left foot, and I fell with my foot on that oxygen tube. Well, it took the same progression as the one on my left foot. I was seeing the wound care doctor, and he was saying the legs need to come off. I saw a surgeon, and he said the legs need to come off. I went to Mayo Clinic and talked to them, and they said the legs need to come off. And then it was a little tough going through it without my wife. She died in 2018 she'd had cancer for 7 years. So going through this without her there, it was a downhill progression, and to the point that I even, I've never been so depressed and in such despair. Dr. Bunte came in and he stood down at the bottom of the bed and he looked at my feet and he said, you know what, I think I can help you. And that was the message that I was waiting for. Somebody to say, I think I can help you.
It was a glimpse of hope, that, hey, somebody's finally listening to us and somebody can finally help us. I think that was a turning point for us to know that there's somebody out there that's going to try something different.
With new technologies, including the deep vein arterialization procedure we've started here in March of 2020, it has revolutionized how we treat these quote-unquote no option patients who really have no other option other than having their leg amputated, and provides a lot of hope to these people.
Mayo Clinic said I was the worst case of arterial sclerosis they'd ever seen. And that's why they said, yeah, your legs need to come off. But when I told them a little bit about what Dr. Bunte had said and what he was doing, they were saying, you're going to get better treatment there than you would here. So go with that, and blessings to you. I went into those surgeries with complete confidence. The fear was gone.
We use an artery in the top of the lower leg below the knee and connect it to a vein. And then in that vein, put stents all the way down to the ankle. And that allows the blood flow to get to the foot through an unconventional means through the veins, and then thereby provide blood flow to the foot. He went through multiple procedures, but the end result, I think he would agree, is worth it. And sure gives me a lot of satisfaction to see him do so well.
Finally, I can say, the wound doctor has dismissed me, home health care has dismissed me. I got a schedule for next Tuesday to go get shoes fitted. And so I'm excited and I'm very positive. I'm already making plans for what I'm going to be doing here in the future.
Looking back, yeah, it was a struggle, and there were times of, depression and stuff, and the outlook seems grim. But when somebody gives you that little, support and help and hope, your outlook is so much brighter.
You can see a pretty dramatic change from when this all first started to where he's at now.
He's found joy in his grandkids, and that's why, as for me and my family, we spend time together. Because you never know when that might end.
Well, I have a pretty cool family. I live in the house with my daughter and son-in-law and my youngest grandson, and they have helped me tremendously.
My daughter can share such a special bond with her old papa that I got to share with him, and so I think that's really sweet and that's really helped him.
I owe it to, first of all, God doing miracles in my life and the support that I've had. But I can thank the doctors, and especially Dr. Bunte, who gave me the hope that I was going to be able to go on in life and keep my legs.
I think one of the great things about working at St. Luke's is being able to offer that hope through innovation, and it's not a cliche. It manifests now with Mr. Thomas's really poignant story. The Promise 2 study is now completed. That was the study that Mr. Thomas was enrolled in, and I am really pleased to say that the amputation-free survival, meaning patients' opportunity to survive without an amputation at 6 months, was well over 70%. 100% of the patients enrolled in this study would have had their leg amputated as a no-option population.
It is important that we keep doing the research that we might get better and better at solving the issues that take away the joy and the life from people. You can't say thank you enough. And people don't understand how overwhelmed you feel by all of these odds that are against you and everybody telling you you're not going to make it and it's not going to happen. But the people that were there for you when you needed them are priceless.